We're going to begin discussing endocrine medications. So, we know that the endocrine system consists of organs and glands all throughout our body that secrete hormones that work together with the central nervous system to regulate metabolic activities and maintain our homeostasis. So, sometimes different elements can get thrown off, or people can have different disorders, and those hormones have to be supplemented because they are essential for our body's function. So the medications that we can use are either natural or synthetic hormones, hormone-like substances, or drugs that stimulate or suppress hormone secretion. So this picture is kind of just a simple way for you to review things you should already know. So the hypothalamus is kind of the main dog, I guess, the coach, as said here, where it is going to see what needs to be sent to release those hormones. And then that'll be sent to the quarterback, which is the anterior pituitary, and throws the signal to stimulate or to those stimulating hormones. And then the receivers are the target glands, whatever is being needs to be released. So those catch that signal and secrete the final hormone. So as you know, there are stimulating hormones and there are the actual hormones themselves. So that will make sense and is very important for you to understand the distinction as we talk about the thyroid, which is what we're going to cover in this presentation. So this little note here, endocrine disorders are either a failure of the gland or a failure of the signal, and our drugs are going to act as the referees to restore that balance. All right, so when you hear thyroid, what do you think? I think metabolism. So if you can remember that, it helps you know what the patient's going to look like if their thyroid levels are high or if their thyroid levels are low. Okay, so if they're high, that's going to look like a really high metabolism. You might see weight loss. They might have like a manic type energy, tachycardia, increased cardiac output. They can actually develop that exophthalmos, which is the bulging eyes. You can look up a picture of that. I don't think I have one of these in that slides, but there's also an extreme side of that, which is called a thyroid storm. The flip side of that is hypothyroidism, where their thyroid levels are too low. And so their metabolism is very slowed down. So that's going to look like coldness, decreased heart rate, fatigue, weight gain, and lethargy. And then the extreme of that is called a myxedema coma. So it can be confusing to remember which terminology as far as the extremes of these. So coma, think they're asleep, right? And with your metabolism, everything's slowed down if for the hypothyroid. So remember that myxedema coma is going to be everything is slowed down. Thyroid storm, everything's sped up. Another name you might see associated with thyroid storm is thyrotoxicosis. And one of the key signs of the thyroid storm or that thyroid toxicosis is a fever. And both of those things are emergencies, the myxedema coma and the thyroid storm. This is just another picture that could help you distinguish between the high and low. And this is just another one. So euthyroid is what you're looking for. That's going to be the normal thyroid levels. Now remember, at the beginning I said that it's important to know the distinction between the thyroid stimulating hormone and the thyroid hormone itself. So our body works on that negative feedback system. And so if it senses that the thyroid is low, that thyroid level, the T3, T4, those are low, what would that be? Hypothyroid, right? So what do you think your thyroid stimulating hormone, would that be high or low in hypothyroid? That's going to be high, right? Because it senses that it's low, that those levels are low, and so it's stimulating more release, okay? So you would expect in hypothyroidism for the thyroid stimulating hormone to be high and the thyroid hormones to be low. The opposite of that would be true for hyper. So if it senses that the thyroid levels are high, that thyroid stimulating hormone is going to be low because it doesn't want to stimulate it. Okay? So when we medicate patients for supplementing hormones or suppressing them, if I'm giving you thyroid hormone because you have hypothyroidism and I'm supplementing that by giving you thyroid hormone, what do you think is a risk? Hyperthyroid, right? So I could accidentally give you too much and then we're going to be on the opposite end, okay? Because you're truly just replacing that thyroid hormone. Okay, so the medications here, that we'll go a little more into these, but I feel like this does a good job of just showing them. So for hypothyroidism, the most commonly given medication is levothyroxine, which is synthetic T4. And very important to know that people will be on that forever. They need to take it early in the morning so that they can go to sleep at night because that's stimulating their metabolism. And it needs to be taken on an empty stomach with a full glass of water and wait about 30 minutes before they eat something. Like I said, we're going to monitor for those hyperthyroid symptoms. And what's that going to look like? It's going to look like their metabolism is elevated, right? So you could give them so much that they end up in, will they have a thyroid storm or a myxedema coma? Thyroid storm, right? Because we're giving them too much. Okay, so hyperthyroidism we can treat with PTU or methimazole. Um, You can remember the PTU by preventing the thyroid up. So you can remember that that is for the elevated thyroid hormones. That can be given in the first trimester of pregnancy. There is a risk for hepatotoxicity with that. Um, and then methimazole is usually what is given to most people, but it is teratogenic in that first trimester. So most of the time, if a person's pregnant, they're going to take the PTU the first trimester and then methimazole the second, third trimesters. Both of those have a risk for agranulocytosis, so we want to make sure if our patient reports a sore throat or we're going to monitor their white blood cell count to look for um, elevated white blood cells. Okay, this is just another way to look at this. This also includes radioactive iodine, which we will discuss on another um, slide. Okay, so our first replacement that we're going to talk about is levothyroxine. This is going to be indicated for patients with hypothyroid. So we want to make sure that we are monitoring their thyroid levels because, again, if I give them too much of this, they could potentially have too much or hyperthyroidism. It is synthetic T4. The indications for this are if someone's in a myxedema coma, if they just have hypothyroidism, or if they have had their thyroid removed because they had hyperthyroidism or cancer, then they need this to supplement. So this levo is elevated, just shows what could happen if you give too much. So we would be monitoring our patients for those symptoms, in addition to monitoring for their levels. Another consideration with levothyroxine is it is usually ordered in micrograms, and so you want to be very careful to ensure that it is, and that you're not given milligrams instead of micrograms, because you would be giving exponentially more medication that could be a deadly error. And again, we want to give this in the morning. We're simulating our body's natural hormone release. So on an empty stomach, 30 to 60 minutes before breakfast, with a full glass of water. And that's going to help prevent that insomnia. We want our patients to know that they have to take this forever. They don't have the ability, their body is not going to make this hormone, so it has to be supplemented. They can't just stop taking it. And if they stop taking it, their metabolism is going to stop. And if that stops, eventually they are going to go into a myxedema coma. And if it's not treated, they are going to die. So very important for us to teach them to take this. There is potential, or it can take up to 8 weeks for it to reach full effect once they start taking it. And then they do have the risk of toxicity. So if they take too much of it, so we want to tell them what that would look like, and that they don't need to take it if they develop that, and that it is an emergency. It does have interactions with medications also. So if they're on an anticoagulant, what are some examples of those? Like warfarin or heparin, it can increase their bleeding risk, and so it requires a reduced dose of that anticoagulant. It can also decrease digoxin levels, so they might need increased digoxin. And then it might require an increase in anti-diabetic medications as well. Okay, so one of the biggest things with this is just making sure that you teach the patient to report signs of diarrhea, fever, tachycardia, irritability, and vomiting. And then just over the time of them taking it, we'll make sure that we are rechecking their thyroid stimulating hormone, as well as their T3 and T4. As far as other warnings, there is actually a black box warning for levothyroxine, because it is contraindicated for treatment of obesity or weight loss. So I don't know if any of you know anybody who has been diagnosed with hypothyroidism and started on Synthroid, is the other name for levothyroxine. But I know someone who lost 100 pounds when they started. And so if someone did not know, they might be like, well, heck, if I can get my hands on some Synthroid, then I don't need to diet, right? But that could kill them. So very, very important that people know not to share their medication, and know that that is not an indication for this medication. That is a result or a side effect because that person's metabolism kicks in, basically. Um, we want to be real careful in giving this to people who've had recent MIs or cardiovascular events, because of the strain it can cause on the heart. And then making sure that we're monitoring their levels and avoiding or taking into consideration those interactions with the other drugs. It's also really important that once they've established, like euthyroid, that good level, that they're not changing the brands of their medication, because there can be differences amongst them. All right, so now we're going to talk about anti-thyroid agents. What do you think that an anti-thyroid is going to do? It's going to lower our thyroid levels, right? So these are used to treat overactive thyroid, like in Graves' disease or hyperthyroidism. The main drugs that we use are PTU, or propylthiouracil. That sounds good. Or methimazole. So PTU lowers T3 levels faster than methimazole, but it does have a shorter half-life, so you have to give it a lot more frequently. And methimazole is once daily. So again, the methimazole is the preferred treatment unless the person is in their first trimester of pregnancy. So I believe I have the contraindications and side effects on the next page, so I'm keeping going. Yes. So, cautions here, like I said before, are agranulocytosis. So we're looking for the patient presenting with a sore throat or a fever. Um, if they present with that, we want to make sure that we're monitoring their white blood cells. So if their white blood cell count has decreased, then we are going to have them, and they're presenting with a sore throat or fever, they need to stop that drug, and make sure that we're managing their levels and keeping them safe, because they could become um, immunocompromised. They could be at risk for infections, which would cause new issues. There also is a black box warning with PTU for severe liver injury, so we want to make sure that we get a baseline of their liver function. So we'll measure their LFTs, and then we'll teach them to monitor for what that would indicate hepatotoxicity, jaundice, pale skin, pale stools, those things. Okay. The abdominal pain also. Um, So, same concept as I said before. If now I'm giving somebody too much anti-thyroid, what potentially could happen? They're going to look like they have hypothyroid, right? So their metabolism is going to be slowed down. So bradycardia, they might gain weight, they might be lethargic, so those doses need to be adjusted. Okay, next is radioactive iodine. Sorry about that. And this is going to, the goal of this is to damage the thyroid tissue. Okay, so it is actively attacking it in order to suppress it so that we can combat that hypothyroidism. So it can be given for thyroid cancer or severe hyperthyroidism. Um, we expect that if we are administering this, that they are going to need supplemental lifelong levothyroxine, because now we've caused their thyroid not to work properly, if that makes sense. Um, Very important that we make sure that the patient isn't pregnant or lactating when we administer this. So sorry if y'all can hear my phone. I have it on silent. I don't know why it's going off. Okay. And then another consideration with them taking this is that they actually maintain this medication in their body for several days. Um, so they can't come into contact with children, or pregnant women need to make sure that they are flushing the toilet twice after they use it, because it could remain, you know, where people could come into contact with it, because it can be excreted in urine and feces. Okay, then there is something called Lugol's solution. This is considered stable iodine versus the radioactive. Um, this is used for thyroid storm and to decrease the vascularity and make the thyroid more stable prior to thyroidectomy. It rapidly blocks the release of the thyroid hormone. We want to monitor for signs of iodine toxicity. It does have like a brassy taste, so we need to tell our patients, or we need to ourselves, mix with like a fruit juice to try to mask the flavor. It can cause stomatitis, which is just oral inflammation or like sores and painful swelling of their oral cavity. It also can cause GI upset. Okay, so I've already told you about this inverted labs with these. So we want them to be on the um, to mimic our body's normal response. Okay. If their thyroid levels are too high, they have thyroid cancer, they may have to have a thyroidectomy. If they do, we have to make sure that there is a emergent tracheostomy tray at the bedside in case there is swelling or hemorrhage. It compromises their airway. We want to check to see if there's any changes in their voice that could indicate laryngeal nerve damage. And then because the parathyroid glands sit directly behind the thyroid, they are frequently removed by accident. So we would need to monitor for signs of hypocalcemia, like tetany or tingling, and we would have calcium gluconate available to supplement. All right, so just as a reminder for these first two, um, the little memory aid, the Levo is elevated. The PTU puts the thyroid under. And then a new one, I don't think I've said yet, I wouldn't give meth to a pregnant woman. I don't love that because you can give the methimazole in the second and third trimester, but just remember that you can't give it in the first trimester. All right, and that is thyroid.